There's only one or two very small studies which say that it may be useful. One study by Sridhar et al. Done on post-op cardiac surgery patients with acute renal failure, when they randomized them to receive a combination of mannitol, furosemide and dopamine, they found that there was decreased need for dialysis. But this was only the one or two studies that I came across which said that okay, you can use furosemide or dopamine in a setting like this. Another study by Flynn et al. Showed that use of IV furosemide showed no clinical benefit in comparison to not using the furosemide as an infusion. A study by Brown et al. Way back in 1981 showed that there was an increased risk of deafness with use of high dose of furosemide. Solomon et al. Found that with the use of furosemide, they found that the prevention of radial contrast nephropathy was actually deleted when you use saline infusion with the help of furosemide. If you see this figure, you find that with saline there has been a significant reduction in the risk of causing contrast-induced nephropathy, as against with the use of furosemide, the risk sort of was remained the same or was much higher. Schilde et al. Found that use of furosemide was probably of not much benefit or maybe even trended to have harm. And so also another study in a post-operative acute renal failure, it was found that the furosemide caused, the use of furosemide, there is 15% higher risk of developing acute kidney failure and progressing on to requirement of renal replacement therapy. But the nail on the coffin was probably hit by Mehta et al., who in a large multi-centric study, which was a 6-year cohort study, showed that in about 500 odd patients, use of diuretics was associated with a 68% increase in in-hospital mortality and a 77% increase in the odds of death or non-recovery of renal function. Now, this was not a randomized trial of any sort, but it was more to do with what is known as propensity scoring, wherein based on a cohort group, the patients are actually matched to having received furosemide versus not received furosemide, and this matched comparison was actually done. So if you actually see on this chart, the open circles are the patients who did not receive any diuretics, and you find that the creatinine sort of remained stable through that course as compared to you find that the creatinine actually decreases with progressive stay in the ICU, as against the patients who required furosemide, there was an increasing trend. So also the case with blood urea nitrogen and urine output, they found that there was an increased risk of causing renal dysfunction or worsening renal failure with the use of furosemide. This also translated into an increased mortality in these patients who received furosemide of variable dose. So, what are the reasons for which furosemide failed the initial experiments or initial success which was thought of by various physiologists and clinicians? The possible reasons could be: one is direct nephrotoxic effects, either by causing direct renal tubular injury. Second one is there is a pseudo elevation and sustained urine output that is artificially driven by furosemide, because of which there is underestimation of renal injury. And you believe that there is patients passing urine, the numbers are getting worse, it doesn't matter if you wait for dialysis. The second, and because of which there is delayed initiation of renal replacement therapy, and as we all know, renal replacement therapy itself is associated, delayed initiation of renal replacement therapy itself is associated with an increased risk of mortality and morbidity. Intravascular volume depletion can also result in critical inpatient when you use diuresis. Now, all this was again upturned by a study by Uchino et al., who actually did a prospective multi-centric multinational trial involving over 23 countries. They actually put to test this subset of patients with 3 different types of multivariate models, and found that diuretics, particularly furosemide, which was used in over 98% of patients in ICU patients, actually probably didn't independently cause acute kidney failure, and there was no evidence of harm. So ultimately, should we use furosemide or not? I suppose it will depend on the clinical circumstances, but I think it's better be avoided as far as possible unless there are specific circumstances on which furosemide need to be used. because in the absence of any benefit and possible potential harm, especially in critically ill patients or in early kidney or early renal kidney injury, I think it is better that furosemide be avoided if possible. The next was low-dose dopamine in renal dysfunction. Rational of use, healthy volunteers were found to have increasing renal blood flow causing natriuresis and diuresis. So based on this, for about 2 to 3 decades, it was a common practice across the world to use dopamine, low-dose dopamine, to actually prevent progression of acute kidney injury. But all this was thrashed out by a large study done by the ANZIX group in the Australian ICUs across Australia and New Zealand, where about 328 patients were randomized to receive dopamine versus placebo, and they found that there was actually no benefit in doing so. A subsequent meta-analysis by Kellum et al., which included the studies which included the ANZIX CTG study as well, showed that there was no benefit in terms of mortality, no benefit in terms of resolving acute renal injury, nor any benefit of decreasing hemodialysis with the use of dopamine. If at all, there was a slight trend towards a worse outcome with the use of dopamine in various subgroups that they had actually done the meta-analysis on. What are the reasons for why dopamine failed the initial promises that it made? One, it was the pharmacokinetics may not be as predictable in a critically ill patient as they do in healthy volunteers. Like most drugs in critical care, the pharmacodynamics of critically ill is far different from what we see in otherwise normal non-ICU patients. There's also increased plasma renin activity in most ICU patients, especially when they are having various forms of endothelial dysfunction and shock, which therefore may counteract the effect of dopamine. Hysteresis exists in the effect of dopamine on renal blood flow and severe sepsis, which means the same pattern is not followed. The same pattern is actually not followed. Medullary dysoxia is a demand-based problem. Now, hypoxia present in the medulla, particularly in patients, when you actually give furosemide, although it might try to decrease the oxygen requirement, here the reason for failure of dopamine is possibly because the oxygen demand itself is very high. So dopamine may not actually promise the problem that it actually, may not actually fulfill the promise that it actually made. It causes diuresis and natriuresis, and in a critically ill patient with intravascular volume depletion, diuresis may be bad. It may be harmful on splanchnic circulation because of what, similar to a Steele syndrome which occurs in various other settings. There may be shunting of the blood to the rest of the splanchnic circulation and therefore decreasing the blood flow into the afferent arterioles of the renal vasculature. There is a lot of evidence in animal studies and clinical experimental studies to say that it is harmful on the endocrine system. It actually causes suppression of the growth hormone, suppression of steroids, suppression of various immunoregulatory systems as well, and can also blunt the ventilatory drive, which is often very essential in many of the critically ill patients. So in summary, diuretics may not be useful to be used in critically ill patients, particularly when they are trending to have acute renal dysfunction. Though no harm, but benefits still seem quite questionable. Certainly there is no role for the of low-dose dopamine as a strategy to prevent early acute kidney injury. The next controversial medication was used for decades and now being abandoned is use of steroids in traumatic brain injury. For nearly 30 to 40 years it was believed that steroids may be helpful to prevent secondary neuronal damage. The rationale of its use was to decrease post-traumatic inflammatory changes that occurs in most patients with traumatic brain injury. A survey in the United Kingdom done in 1996 showed that about 14-15% of ICUs across the United Kingdom used steroids for traumatic brain injury. Previous trials, which totally amounted to about 2,000 patients, showed doubtful benefit/harm with the use of these steroids. So there was a large randomized control trial abbreviated as the CRASH trial, which was a multi-center trial in many centers from India as well. Over 10,000 patients randomized to receive methylprednisolone versus placebo. And the result, there was actually a trend towards worse outcome with the use of corticosteroids in traumatic brain injury. Now, what was the reason for the worse outcome? That was not very clearly shown by the CRASH trial. In fact, most complications were pretty much the same in the patients who received steroids versus those who received placebo. However, in different subset of patients when they were analyzed, if you see, be severe brain injury, moderate brain injury, early onset within 1 hour after the trauma to hospital. Everywhere the trend was towards a worse outcome. So the reasons for this is still not very clear. And this risk actually persisted up to 6 months. When a follow-up study was done 6 months later, of about 70% of patients were called back, and the follow-up study showed that this risk of mortality actually persisted up to 6 months when they actually analyzed these patients when receiving steroids with traumatic brain injury. Subsequent meta-analysis by the Cochrane group also demonstrated the same risk. Of course, the defect of the study or the limitation of the study was that it was heavily biased by the crash trial, because about 80% of the patients were actually contributed by the crash trial. So therefore, this meta-analysis is pretty much a replication of the crash trial per se. So therefore, there is no role for steroids, definitely no role for steroids in traumatic brain injury. Now, the use of neuromuscular blockade in ICU. What are the indications for which we use this? One is to facilitate mechanical ventilation, particularly in patients who have difficult ventilation, either because of bronchospasm, asthma, COPD, or ARDS, to facilitate the initial endotracheal incubation or better tolerance of the endotracheal tube. Various procedures in the ICU, for instance, diagnostic bronchoscopy, etc., when we do use neuromuscular blockers, to control intracranial pressures in patients post-traumatic brain injury or any other form of raised ICP, wherein despite optimal sedation and optimizing all other physiological parameters, we do use paralysis or neuromuscular blockade either as boluses or as infusion if patients actually require them to control ICPs. Reduction of muscle tone in certain specific medical conditions like tetanus or neuroleptic malignant syndromes. A study by Arolge et al. The analysis of a large database involving multi-centric multinational study, they found that the usage of neuromuscular blockers was about 13%, which is far less compared to what it used to be about 20 or 30 years ago. This, of course, is attributed to better understanding of the problems of neuromuscular blockade and also better modes of ventilation that we have these days. The median number of days for which neuromuscular blockers were used were only about 2 days, and which contributed to only 8% of the total number of ventilator days in this huge cohort of patients. What were the factors associated with the use of neuromuscular blockade? Independently, some of the factors which determined the use were age. Younger people required greater incidence of use of neuromuscular blockade. For some reason, higher incidence in male patients, possibly because they contributed a larger proportion of these patients. Functional status, so the patient who is otherwise extremely moribund, sick, with some other neurological problem, had lesser chance of requiring neuromuscular blockers. The reason for which the patient was ventilated, including various complications related to mechanical ventilation and various other management strategies. Now, what are the outcome with the use of neuromuscular blockade by this study, which is published in the chest by Arolge et al. Found that those patients who received neuromuscular blockade independently were associated with a higher risk of mortality, which means irrespective of the patient's underlying pathology, use of neuromuscular blockers or paralysis independently predicted a higher risk of death or higher risk of morbidity with these patients. They had longer duration of mechanical ventilation with a median of 7 versus 3 days, which was found to be statistically significant. Longer duration of weaning from mechanical ventilation, longer duration of staying in the ICU as well, 10 versus 7 days. What are the complications that we find in patients who receive neuromuscular blockade? First and foremost, inadequate sedation and analgesia, because we are not able to assess the depth of sedation, we are not able to assess the wakefulness of the patient when they are paralyzed, and therefore we often end up causing distress to these patients with sedation and analgesia. In fact, a study about a few years ago, when they retrospectively asked ICU patients who had received paralysis, about 50% of them said that they could actually appreciate these uncomfortable feelings like suctioning, placement of a central line, etc., despite being sort of quote-unquote optimally sedated with paralysis. Inadequate ventilation in the event of a ventilator circuit disconnection is a significant risk. Difficulties in assessment of patients, particularly the neurological assessment, becomes very difficult if paralyzed patients. With prolonged use, they develop tachyphylaxis, which means you have to use higher doses associated with higher risks. Inability to cough causes retention of secretions and atelectasis. Hemodynamic changes, immobility itself causing risks such as pressure sore or thromboembolic complications, peripheral nerve injuries, all which wouldn't have otherwise occurred if the patient was not immobilized so badly, and also the risk of prolonged muscular weakness. Now, what are the risks of prolonged muscular weakness? What are the reasons? One is the alteration in pharmacokinetics, because drug interactions with neuromuscular blocking agents can cause prolongation of the action. Accumulation of either the parent compound or its metabolites can prolong the action. Various electrolyte and metabolic rearrangements and hypothermia are some of the reasons for which the prolongation of the action of these neuromuscular blockers occurs. Just one more slide to go. Functional alterations in the motor unit, which manifests itself as various forms of myopathy or neuropathy, which is now known as critical illness polyneuropathy or polymyopathy. And in fact, it has been found that steroid-based neuromuscular blockers such as lecuronium, etc., have actually been found to be associated when they use aminoglycoside or steroids. There is an increased risk of what we call critical illness polyneuropathy. And there's also been some studies which show that there have been inherent defects in the neuromuscular junction, especially in the acetylcholine receptors, which cause these problems. So I think in short, neuromuscular blockade needs to be used, but very, very cautiously and very, very judiciously.
Thank you, Dr. Sunil Karan, for giving me the excellent presentation.
Please sit there for 5 minutes. 2 minutes. 2 minutes.
I will invite a questioner from the audience.
Okay, Sunil, thank you. Thanks, Sunil.
Thank you very much, sir. My one question to the audience, please hear carefully. 600 delegates, 300 days preparation, still 150 doctors present in the hall, 60 days reminder via phone, SMS and the email, 30 topic, 10 national speaker, 2 international speaker, and the one name, who is he? Please call Dr. Rajesh, please, Dr. Rajesh Mishra. Please be stand up and give him the stand up oration. Please be stand up. I hand over mic to Dr. Rajesh for thanks. Dr. Rajesh, please.
Thank you, and I am overwhelmed. But it's your presence and cooperation and support. That's why I'm able to do. And I promise we will bring even better next year.
Yeah. 2 days.
It's not 2 days, you will get, I promise, in 1 day you will get complete review of critical care. First day, we are now planning that we will give you hands-on training. But 1 day, I promise that you will get complete review of critical care, what is happening in 1 year. That much. That sort of faculty.